Greetings. I can see about 20 of you want to know the bad side and how to avoid it. Now, X-ray is classified as a carcinogen by WHO. Healthcare workers are exposed to this radiation in two ways. And the people who are healthcare workers like intervention cardiologists, orthopedic surgeons, spine surgeons, and most of the studies have been done on them. It comes to us through direct exposure when you come between the beam and the collector, or it is a scatter radiation, which is more important in the surgical setting for the rest of the personnel who don't come between the beam and the collector or magnifier. Now, radiation in an intervention electrophysiology lab, it was found that radiation dose received to staff was significantly higher in the people who were working in that environment compared to the other people who were not working in that environment in the same lab. So site matters, means where there is a radiation source, there is a problem. The intervention cardiologist received the highest dose compared to the other personnel who stay little far apart, who operate the machine. So the distance also matters. In another study, they found that in the group of people who were exposed to radiation, the risk of cataract formation was 71% versus 7.1%. That is 10 times more chances of you developing cataract if you work in that environment. So radiation also matters. In a French multicentric observational study, they found that a particular location of cataract is more common in the radiation group, that is a posterior subcapsular lens opacity. In some observational study, it was found that among hospital employees, being an orthopedic surgeon was an independent significant risk for cancer development. A logistic regression analysis working as an orthopedic surgeon significantly increased the risk of tumor. These are all well documented. In Taiwan database, it was found that the cardiologists who did more than 15 procedures had a higher chances of developing malignancy versus the people who did less than 15 procedures per year. 31 case cohorts were studied. These are the people who were either cardiologists, electrophysiologists, intervention radiologists. They had all worked for a very long period. In 2 decades, and the tumor was in 31 case cohorts. 55% were GBM, that is glioblastoma multiforme, 16% meningioma. These are the 2 radiation-induced tumor. Interestingly, 85% of these tumors were on the left side of the brain, the side which is exposed to radiation in the group. So radiation has 2 types of damage, stochastic and deterministic. Deterministic is for you people who are young. Stochastic is for me and Dr. Sharma. We have already had it, so we don't know what is going to happen. In deterministic, it is directly dose dependent. You have skin erythema, alopecia. Ask any person who says, I do a lot of minimally invasive surgery, and if you find hair on his hand, don't believe him. It just goes away. The problem is stochastic because you don't know, it is not a dose dependent, and the effect is known after several years, decades, something will happen. Maybe you are genetically programmed for it. So radiation exposure has been shown in pedicle screw, in T-leaf, lumbar fracture. There is a significantly high radiation, and anyone will tell you who does the procedure. And the procedure with the highest radiation exposures are OLIF, pedicle screw fixation, and kyphoplasty. Now, studies have been done how much radiation exposure to all the people, and you can see that the hand receives very high dose. If the patient is fat, you get more radiation. Basically, larger specimen, ipsilateral screw, where the source of the radiation is, you get more radiation. The greatest level of the radiation is on the side where the primary radiographic beam enters the cadaver. In a fluoroscopic time of 37 minutes, I know my colleagues, they will not tell you openly, for early days of pedicle screw fixation, they have done 80 to 100 X-rays to get the right positioning. So you can see that the surgeon receives the maximum amount of radiation. And to remain below the maximum yearly permissible level of radiation, the estimated total number of minutes for the surgeon would be 453 minutes. So what is the major determinant of scatter radiation? Higher kVp. So you ask for, give me a better film, remember you are going to give higher kVp, and larger field size and more obese patient. So there are three cardinal rules of external radiation protection: time, distance, and shielding. Increased radiation is a fact in MISS. The only question is how to reduce it. So International Council of Radiation Protection has given a guideline that in occupational exposure should be limited to a maximum average of 20 milli-SV per year over 5 years. However, that was for the radiation workers. It was not meant for doctors. For doctor, it is 1/3 of this dose. Despite the knowledge that the operating surgeon's hand should not come in the path of direct radiation, in 15% cases, the surgeon's hand has been caught in the fluoroscopic beam. And each time it is caught, you get 100 times more radiation in your hand. If the surgeon's hand, as I said, 100 times more. So you have a personal protective equipment, which is the most neglected part of any operation theater, thrown in a corner. A body lead seal reduces radiation by 94%, and a thyroid seal reduces radiation by 96%. If you use them, you can do immense number of operations, provided those shields are not broken. The Alara principle says that radiation should be as low as possible, reasonably achievable. So how do we minimize radiation in fluoroscopy? There's a pulse mode where you give intermittent X-rays producing short pulses of radiation, and low dose mode. You can use collimator, intermittent fluoroscopy, and last image hold techniques, which experience it should be taught to everyone. The distance matter. It reduces to 0.1% at 3 feet distance and 0.025% at 6 feet distance. That is after wearing the shield. Up to 100 centimeter, it keeps on decreasing and then it stabilizes. So this is a scatter radiation. You see where the beam is. This tells you how to position the beam and where you are going to get radiation. Bottom part is better for the older people. This is the position of C-arm. It is considered that if the source is below the table, it is better. If source is away from the surgeon, it is better. So you learn to minimize fluoroscopy by using navigation, which is you have to have a true AP and lateral to avoid mistake, because you're taking 2D imaging to make 3D reconstruction in your hand. Further new things have come: radiation dose, intraoperative C-arm fluoroscopy, portable X-ray, and O-arm. They all give radiation. The question is to whom? O-arm gives, you can go out, so it gives more radiation to the patient. You can use navigation to reduce the radiation, there is no doubt about that. You can plan it properly, but remember, the navigation can go wrong. This is an X-ray film of the same point where navigation showed and X-ray showed. For that, we have now O-arm and other things. The best is robotic mount, where you can, it has been found in a controlled trial, the radiation reduction is 62.5%. So, thank you all, be safe. Most of all, you will not be using O-arm. Most of all, you will not be using robotic. So you have to learn to use fluoroscopy very intelligently. Okay? Thank you.